Hello and welcome everyone to the May 2024 edition of Eversight's webinar series. This is Understanding Ocular Graft-versus-Host Disease, Current Insights and Future Prospects with Dr. Sarah Sunshine of the University of Maryland. Quick couple of housekeeping notes before we get started. This webinar, all of our webinars are recorded, available on demand on our website and YouTube. Also, please keep an eye on your inbox for more webinars coming up this year. All participants will be muted throughout the duration of the webinar, but please do ask questions. You can do so at any point during the talk by using the Q&A panel that'll be at the bottom of either your phone, tablet, or computer screen. We'll answer questions. Dr. Sunshine will answer questions at the end of the talk. So now on to tonight's speaker. Sarah Sunshine is an assistant professor of ophthalmology at the University of Maryland School of Medicine in Baltimore, Maryland, specializing in treatment of corneal and ocular surface disease, focused most specifically on our topic tonight, ocular graft-versus-host disease. Sarah did her cornea fellowship training at one of our favorite partner institutions, the Illinois Eye and Ear Infirmary. Dr. Sunshine treats complex corneal diseases, dry eye disease, performs ocular surface repair surgeries, cornea transplant surgery, and complex cataract surgery. In addition to her clinical practice, she's developing a biobank for studying GVHD, and her research program will allow for better understanding of the mechanisms of disease, identifying novel treatments for the disease, and developing better therapeutics. And so now I will hand the floor over to you, Dr. Sunshine.
Thank you so much for that introduction. It is truly a pleasure to be with you tonight and to have the opportunity to from Eversight to share my interest in ocular graft-versus-host disease. I'm particularly grateful to Eversight since they gave me my first grant to support my research here at University of Maryland. It's been a wonderful partnership for me. So it's a pleasure to be here. Thank you. So again, I'm Sarah Sunshine. I'm an assistant professor of ophthalmology at University of Maryland and a member of the University of Maryland Greenbaum Comprehensive Cancer Center. And I'm going to talk to you today about understanding ocular graft-versus-host disease. And we're going to talk about current insights and future prospects. So where we are now and where we're going. So this is the outline of the talk tonight. I'm gonna tell you what is graft-versus-host disease and ultimately ocular graft-versus-host disease. How do we diagnose it? How do we treat it? What are the gaps in our knowledge and how can we close those gaps? So what's next afterwards? So since most of us are ophthalmologists or future ophthalmologists, and our focus is really on the eye, I really want to take a step back here and take the opportunity to talk about who gets graft-versus-host disease and ocular graft-versus-host disease, so we can understand who's at risk. So who do we need to think about ocular graft-versus-host disease in, and why understanding that will explain why we get ocular graft-versus-host disease. So graft-versus-host disease affects about 50,000 to 100,000 patients in the United States. It affects patients who have received a stem cell transplant, go on to develop graft-versus-host disease. And there's both an acute and chronic phase. And the indications for this stem cell transplant are largely to treat malignant disorders like leukemia and lymphoma and multiple myeloma, but there are non-malignant disorders that we also can use to treat. So what is a hematopoietic stem cell transplant and what does that mean? I'm sure a lot of us learned about this in medical school, but we're going to take a step back here and think about it for a minute. So it's there is a recipient, so that's the person with the disease who's sick, and they for a number of different reasons that we just talked about, they undergo a stem cell transplant. So where do we get these stem cells from? There are a number of different sources. You can get them from the bone marrow, peripheral blood, or umbilical cord blood. And then they undergo, once you've decided that, you can then undergo a conditioning regimen. So what does that mean? So in order to give a stem cell transplant, you have to destroy the host's own immune system and bone marrow. So to do that, you do a either myeloablative or non-myeloablative process. So that again kills all the stem cells in the host's bone marrow. And non-myeloablative is a little bit gentler process and takes a little bit longer to prepare the patient, but it's a little bit better tolerated. And then there are different types of donors. So then there's a donor who gives their stem cells back to the patient. And this can be an autologous, which means the self. So the patient's own bone marrow is used. And so that's stem cells from the same person. And that's used for treatment of leukemias, lymphoma, and multiple myeloma, in addition to other diseases. And that really doesn't lead to graft versus host disease. And then there's also allogeneic donor stem cells. And those are the patients that we're going to focus on, because those are the patients that ultimately can develop graft versus host disease. And there are a number of different types of donors. There's a matched related and a matched unrelated, and that's exactly what it sounds like. So matched related means that they're genetically related to the recipient. And matched unrelated is somebody who is genetically unrelated and yet has similar HLA matching. And then there's umbilical cord blood. And these are all used for treatment of, again, leukemia, blood hematologic malignancies like leukemia, lymphoma, multiple myeloma, myelodysplastic syndrome, and aplastic anemia. And about 20,000 patients per year receive an allogeneic stem cell transplant. So those are the patients who are at risk for developing graft versus host disease. So what's the pathophysiology of graft versus host disease? We're not going to go into great detail here, but basically it's when the donor immune system attacks the host. What's interesting when you think about graft versus host disease and a stem cell transplant is you actually need and want some response from the new immune system against the malignant cells in the body. So that's called a graft versus tumor response. And that's necessary. That's the goal of a stem cell transplant. What graft versus host disease is when there's an overactivation of the systemic inflammatory response, which leads to attack of the donor cells against recipient tissue. So that's the graft versus host disease. And it's both a T and B cell mediated process. It's a T cell mediated process, largely a T cell mediated process in acute graft versus host disease, whereas chronic graft versus host disease is both a T and B cell mediated process. And I'll go into a little bit more detail about what that means in a few minutes, the acute and chronic graft versus host disease. And there's also a decrease in T regulatory cells in the process. So again, what is graft versus host disease? We're still talking about the systemic, more bigger picture disease, and it's a multi-system disease. It affects multiple organs in the body, including the liver, causing cholestasis and transaminitis, the lungs, causing bronchiolitis obliterans, the GI tract. It can cause trouble with oral, esophageal, small and large bowels, as well as the skin. And that's a scleroderma-like process. And it's important to remember we're focused on the eyes, but these patients are undergoing a lot of challenges when they're coming in to see us. And you'll see that we touch upon that later in this discussion. So again, what's the difference between acute and chronic graft versus host disease? So acute graft versus host disease is classically thought about the first 100 days after a stem cell transplant. So that's the initial process. It's more of a T cell, donor T cell response, and it's a direct response to the HLA antigen. This is less common to have ocular involvement, but it's possible. We've actually had a few cases just this year of acute ocular graft versus host disease at University of Maryland. It's more of a conjunctivitis and a really severe conjunctival inflammation, and causes ultimately conjunctival scarring and sublepharon, and carries with it a poor prognosis for the patient. It's important to remember this because most talks or discussions on ocular graft-versus-host disease are about the chronic form, because that's the majority of the patients that we're going to see. But I do want you to just remember this acute ocular involvement. And if you are either there's a consult or an oncologist reaches out to you for help, it's really important to think about this and treat it aggressively, because you really can make a pretty significant difference in the ultimate outcomes for these patients. Chronic graft-versus-host disease is thought about after the 100 days. It's more of an autoimmune-like response. It's both a T and B cell mediated process, and involves interferon gamma. There's a lot more fibrosis, collagen deposition, and antibody production, and about 60% of the patients ultimately develop ocular graft-versus-host disease. So again, this is the patients that we think of when we think of graft-versus-host disease in the eyes. So we're finally here. What is ocular graft-versus-host disease? Again, it's one of the graft-versus-host disease, the leading cause of morbidity after a hematopoietic stem cell transplant. But ocular graft-versus-host disease is oftentimes one of the biggest complaints that patients have after a stem cell transplant. It's really affects their quality of life. And the donor immune cells attack the host tissue, and about 50% of patients after a stem cell transplant are affected by ocular graft-versus-host disease. It's a severe inflammatory dry eye disease. So it causes increased risk of infection, pain, poor vision, light sensitivity, cicatricial conjunctivitis, and in worst case scenarios, it can even cause corneal perforation. And it's caused by breakdown of the ocular surface. So you have inflammation of the ocular surface, which then leads to breakdown of the epithelium of the cornea, and you lose that barrier, which increases your risk of infection, and it can be really debilitating for patients and can really have a big impact on their quality of life. Again, this is a pan-ocular surface disease. It affects every part of the ocular surface, from the tear film to the lacrimal gland to the corneal epithelium, to the conjunctiva and goblet cells, meibomian glands, and corneal nerves. So it's really important that we think about this as when all different aspects of the ocular surface when you're thinking about treatment and diagnosis. So we now understand who gets graft-versus-host disease, who gets ocular graft-versus-host disease, or who is at highest risk. So the next step is to diagnose it. So how do we diagnose ocular graft-versus-host disease? Essentially the gold standard is this International Chronic Ocular Graft-versus-Host Disease Consensus Group, which really lays out a framework in which to diagnose patients with ocular graft-versus-host disease. So we're going to go through that in a little more detail. It has 4 different components. We have corneal staining, and it's a grade from 0 to 3 of the staining, and that's a fluorescein staining that we're looking at. Conjunctival injection, how red is the white part of the eye, and that's a grading of 0, 1, or 2. Schirmer's test is a test of tear production, and allows you to see a functional change. And then ocular surface disease index score is a validated dry eye patient questionnaire that allows you to assess how these changes are affecting the patient's daily life. And you grade each component separately, and then you use these criteria to then give it each component gets a severity score, And then you get a total score. You add it together for a total score. And then what's really interesting is whether the patient has systemic graft-versus-host disease or not, puts them into a different category and allows you to grade it differently. So they need a less high ocular score in order to get if they have systemic graft-versus-host disease, because that increases their risk of having ocular graft-versus-host disease. And ultimately, you can use this diagnostic criteria to decide when to treat and how aggressively to treat. So whether or not they're in the probable graft-versus-host disease or definite graft-versus-host disease categories. There's another test that grading criteria, the NIH criteria for ocular graft-versus-host disease, and this is more of it looks at 3 different components: the symptoms, whether or not the patient is requirement of eye drops, and the effect on activities of daily living. What's interesting here is this really can be done more or less by oncology as opposed to ophthalmology. And there are a lot of differences between these two. So the NIH criteria is the oncologist can perform it. It's based on symptoms, need for eye drops, and change in activities of daily living. There's no exam findings, and it's more subjective. Whereas the international consensus criteria on chronic ocular graft-versus-host disease has to be performed by an ophthalmologist. It does take into account other sites of chronic systemic graft-versus-host disease. It measures tear production, corneal fluorescein staining, a validated dry eye questionnaire, and redness of the eyes. And the limitation is also the benefit to it is that it requires an eye exam by a specialized eye care provider, which makes it a barrier to actually having it performed. So there are some studies that have been performed that look at the difference between these two. And what's interesting in this study that the NIH score missed 26% of patients with ocular graft-versus-host disease. So that suggests that if patients aren't seeing an ophthalmologist, then more than a quarter of them are being missed who have earlier signs and are therefore could be treated earlier and have better outcomes. So I think this is suggestive of the importance of seeing an ophthalmologist earlier. And we'll talk about that in a little bit. So the other thing to think about, when this is not included in that scoring system, is the conjunctival fibrosis in chronic graft-versus-host disease. This is a really nice sign and pretty specific. If you find it, it really suggests active ocular graft-versus-host disease. You can see here that there's different grading criteria, but one thing that I want to stress is that if you don't look for this, it's not something that you're going to see on your eye exam without looking. So you want to flip the eyelids. You want to actually look for this, because it really can help you with modulating treatment and diagnosing ocular graft-versus-host disease. So how do we treat this? The current principles of management, I like to break them down into 4 different components again. So we can think about replacing moisture, preservative-free artificial tears, gels. We can use different ointments, and a personal favorite would be serum tears. And these really are sort of the baseline criteria. So almost every patient that comes in that I see that I'm worried about graft-versus-host disease or ocular graft-versus-host disease, even before they get their transplant, I start them on artificial tears and have a very low threshold for starting serum tears. We then want to think about the eyelids. Again, remember, when we think about this disease, it really affects all the different components of the ocular surface. So we want to treat each one individually and all of them together. So we're going to treat the meibomian gland disease with warm compresses, erythromycin and doxycycline, and monitor their meibomian gland disease. Another thing to think about is these patients have undergone chemotherapy and other treatments for their cancer, and that puts them at higher risk for dry eye, just regular dry eye disease and meibomian gland disease. So it's definitely something to treat relatively aggressively. You want to prevent loss of fluid from the eye, so prevent desiccation. You can do that with soft contact lenses, but scleral contact lenses work really, really well in these patients. You can also use moisture chamber goggles and environmental changes. So you can use humidifiers, you can change the height of the screen, and minimize air conditioning or air blowing on their eyes. And there are lots of different options for preventing loss of fluid from the eyes. And then you can control the inflammation. So the underlying cause of graft-versus-host disease and ocular graft-versus-host disease, we know what it is. It's an inflammatory dry eye disease. So in order to treat it, we have to control the underlying cause. And we can do that as ophthalmologists, both topically with steroids. You can use topical tacrolimus. You can use cyclosporin. But you also oftentimes need to treat this with systemic therapy. Again, it can be a really robust inflammatory response. And if you start with artificial tears and then slowly work your way up to controlling the inflammation, you're going to miss your window of opportunity. So it's important to treat this early and aggressively with steroids or controlling the inflammation, and both topically and systemically. So oftentimes I work closely with our oncologists at University of Maryland to be able to work with them to help with the systemic therapy, because oftentimes we're not able to control the inflammation locally alone. And despite what looks like a lot of options, we really don't have enough options for these patients. It's all treating the symptoms and the signs of ocular graft-versus-host disease, and we're not getting to the underlying cause. And part of that is because we don't know what the target is. We don't know what to focus on, and we don't know how to control the inflammation. This is something that as a fellow at University of Illinois with Dr. Jane, he definitely reminded me of this often, but this is not another dry eye disease. You don't want to start slow and start with artificial tears and slowly add on therapies. You want to treat this aggressively. You know that the cause is from ocular graft-versus-host disease. You know it's inflammatory, so you want to go to something that's going to decrease the inflammation and suppress the immune system. So what are the gaps in our knowledge? How do we help these patients? Before I go into that, what's really striking to me, I'm going to go back to this picture, but what's really striking to me in our patients is that I have a number of patients who will come to me and they're just so frustrated with their eye problems and their eye disease that they will often tell me that had they known how challenging and hard their ocular graft-versus-host disease was, they would never have accepted a stem cell transplant. And if you think about what that means that's a life-saving therapy that they're saying they wouldn't have wanted because it's so debilitating. So I think we really owe it to our patients to work on improving diagnosis so that we can treat this earlier, and also finding better therapies that are more targeted for our patients. So that brings us into the gaps in our knowledge. Are we diagnosing patients early enough? I touched on this earlier in the discussion, but current recommendations from oncology are based on the NIH score and starting at more than 6 months, between 6 and 12 months. And in my experience and my patients, that seems to be too late. So if you wait till they're symptomatic, and if you wait till they're noticing their ocular changes, you've missed your window to treat it successfully or more successfully. So oftentimes if the course of the stem cell transplant is the patients are in the hospital for over a month, and then at the time of their transplant, and then they're seen 3 times a week for months. and that they're coming into our cancer center or to see their oncologist. And it's really, there's a huge burden on these patients and their families. And the last thing they're thinking about at that stage is their eyes, and they're minimizing some of those symptoms. So it's really important. I'm going to show you a little bit of data, but it's important to think about this and work with the oncologists in your system to try and see if we can get these patients in earlier. And then the other question is, are there biomarkers? Can we use the tiers or imaging modalities or different scoring systems to better identify patients who are at risk? And is that an area that we can improve in? So again, we looked at some of this already, but this is a cross-sectional single institution study, looked at 111 patients after undergoing a stem cell transplant over 3 years. And only 54% of the patients had a previous eye exam. And of those patients, 21% of them had signs of ocular graft-versus-host disease who hadn't sought eye care. So again, that gives us an idea of how many patients aren't being seen that should be seeing an ophthalmologist. And we're pretty good at identifying patients with severe ocular graft-versus-host disease. But if you think about it, our treatments aren't great, so we've missed an opportunity if they've gotten to be severe without seeing us. And this is that same paper that I talked about at the beginning of the talk, but 21% of the patients had signs of ocular GVHD on exam who didn't seek eye care. And then there were over 25% of the patients were missed when you only use the NIH score. So that again suggests that you really need to get in to see an ophthalmologist and do an extensive, or a cornea specialist, or somebody who's thinking about graft-versus-host disease in order to really diagnose earlier graft-versus-host disease in the eyes. So there was the 2020 NIH Chronic Graft-versus-Host Disease Consensus Project, which brought together a number of world experts in chronic systemic graft-versus-host disease. Among those were many ophthalmologists and leaders in the field. And what they recommended were a baseline eye exam, so that's pre-transplant or 3 months post-transplant, and then following these patients more closely. And that's because the irreversible changes from ocular graft-versus-host disease occur earlier in the disease than the patients can identify on their own. And once the symptoms are present, it's really too late to reverse these long-term consequences. And you would think, great, we have this, all the experts got together, we now know this. The challenge is that we don't have enough data to support this and really force or encourage patients to be seen earlier. And it goes back to the challenge for these patients with how much burden there is on them to seek care. And then the biomarkers, can we see who's high risk for developing ocular graft-versus-host disease or systemic graft-versus-host disease using tiers, imaging, or a combination of both? So at University of Maryland, we are looking at, we're developing an ocular biobank of patients with ocular graft-versus-host disease. And we are following these patients over 2 years. So we're seeing them at their baseline visit and then pre-bone marrow transplant, and then every 3 months following that. And what's interesting is we expect about 50% of these patients who are recruited are not going to develop ocular graft-versus-host disease. So we have a control within this study, and 50% of them will develop ocular graft-versus-host disease. And the goal is to take different samples. So we're taking tears, impression cytology, and peripheral blood. And we're going to correlate that with their clinical exam and slit lamp photos and other imaging modalities that we're able to take. And hopefully we'll be able to use this to be able to identify biomarkers and novel treatment targets. But the only way that I'm able to do this is because of the relationship that I have with oncology here at the University of Maryland. This really takes a collaborative approach, because otherwise there's no relationship with these patients prior to their stem cell transplant. So I am I'm very lucky to work with wonderful people within the Cancer Center. So if we can diagnose these patients, it's great. We can use the treatments that we have available now to treat them, but is that enough? Can we do better with our treatments? And I think we can. I think we can identify new treatment targets, both locally and systemically. We can also repurpose current therapies and identify new targets. So one quick story that I'm going to talk about is the Janus kinase, so JAK inhibitors. JAK is there is a pathway that's central to inflammation. It leads to cytokine signaling, and it's been shown to be critical for multiple immune-mediated diseases. What's interesting is ruxolitinib is a JAK1/2 inhibitor, which was approved for chronic graft-versus-host disease. And if you look at the literature, there are multiple cytokines that are elevated in the tiers of patients with ocular graft-versus-host disease, and many of those are signaled through the JAK1/2 pathway. And then we looked at just 4 patients within our patient cohort that we had seen prior to starting ruxolitinib, which is a JAK1/2 inhibitor, and post ruxolitinib. And you can see that we found a significant difference in the ocular surface disease index score. So there was an improvement in the symptomatic change in patients on ruxolitinib. And there was a more subjective change in some of the patients who in their staining scores, and their staining on just visualizing the change pre-ruxolitinib and post-ruxolitinib. So it's interesting to think about systemic therapies and how those affect the eyes specifically, and what can we do with that, and how can we use that to our advantage when we're thinking about treating these patients. So we've talked a little bit about how the gaps in the knowledge, and what we're doing at University of Maryland is we're really trying to take a bench to bedside approach. I'm trying to use this biobank of patient samples and take it back to the bench and couple that with mouse models of ocular graft-versus-host disease. And the goal is to find a better understanding of the mechanism of ocular graft-versus-host disease, which will ultimately improve outcomes for our patients, both in biomarkers, earlier diagnosis, as well as finding new treatments. So in order to fully study ocular graft-versus-host disease, I think in addition to the patients and the patient samples, you also need to look at the pathophysiology and understand what we're doing and use it as a model to study new therapies. So we have developed 2 mouse models of ocular graft-versus-host disease, an MHC mismatched model and a MHC matched model. And we use our grading system to evaluate the changes in the eyes of our mice. And you can see that we use a similar, it is based off of the clinical score and the literature of other people's work. And you can see that there's a corneal staining with fluorescein, eyelid changes, eyelid fur changes, and changes to the cornea itself. And we're able to show that there's a dose response with the number of splenocytes, which is how the mice develop graft-versus-host disease. And you can see that there's both an ocular and systemic score. So at the top and the bottom, the black line is the mice who didn't receive splenocytes, and then there are different doses of splenocytes necessary for development of both ocular and systemic graft-versus-host disease. And it's a balance between development of disease and mortality. So we found 2 million splenocytes to sort of be that sweet spot where we are able to see enough disease without mortality. And again, the reason that we're looking in the mice and not just humans is because it allows us to evaluate the disease mechanism, specifically in the eyes, look at novel treatment targets and effects on ocular graft-versus-host disease specifically, and look at novel therapies. And then we're able to then correlate those findings with our clinical data. So if we go back to the tiers in our patients, look at the cytokines and a cytokine profile and be able to use that to tell you, understand the biology. So this suggests a Th1 T cell cytokine profile in patients with ocular graft versus host disease. And you can use the tiers to show specific cells and pathways that are important to the pathogenesis of the disease. So ultimately, again, our goal is to find a better understanding of the mechanism of ocular GVHD to improve outcomes for our patients. We're going to do that with both the mice and humans, and be able to hopefully change the way that we treat our patients and result in better outcomes and better diagnosis. I really want to thank Eversight. They were the first grant that I received when I started at University of Maryland, and they've been a wonderful partner. And I also am really grateful for the opportunity to share ocular graft versus host disease with you, and to present during this webinar. I wouldn't be able to do this without the help of a lot of people, both my mentors at University of Illinois, Dr. Jane and Jalilian, as well as my collaborator and mentor here at University of Maryland, Shufeng Cao, as well as all of the people at Maryland who have supported me, from the Cancer Center to the Department of Ophthalmology, and all of the lab members, from medical students to research technicians, and of course, the people who fund my work, including Eversight. I am very grateful. So if anybody has any questions, I'd be happy to answer them.
Wonderful. Thank you so much, Dr. Sunshine. We thank you as well. And it's really exciting to, see the work that happens from our grant programs. And if anyone on the webinar has any questions, you can enter into the Q&A panel, enter it into the chat. I have a quick question. You mentioned your relationship at University of Maryland with oncology. I'm wondering if you have any practical suggestions on what you've done there to work with oncology and get these patients maybe in faster, get an earlier diagnosis, earlier treatment.
Yeah, so I think that's exactly what you just said, is work these patients in faster. So like all of the relationships that we have as ophthalmologists, our clinics tend to be booked and busy. But if an oncologist reaches out to you and wants help and is looking for help, and you're able to help them rapidly, or in relatively short time, I think that creates a really nice relationship early on. And then you're able to build from there. So you're then able to, develop a relationship with them, and then they'll understand the importance of getting these patients in earlier.
Thank you. We have one question in the chat. Are you aware of anyone that has examined the efficacy of amniotic membrane in ocular graft versus host disease?
Yeah, so an amniotic membrane is a great option. I think that's a great point. I did not have that in my slides. I think the challenge with amniotic membranes is they're good for relatively acute periods, but these patients have chronic disease, and it's not necessarily going to help them to have an amniotic membrane on forever, and replacing it regularly. On the other hand, especially in the acute ocular graft versus host disease, that is definitely something that I like to use, especially a Procera with the ring, which allows you to sort of protect the ocular surface.
Thank you. We have another question in the chat. So first, thank you so much for the great talk from Dr. Omar. What are your recommendations for patients already diagnosed and have long-standing GVHD, very poor response to treatments that are currently available? And it's a two-parter. I'll let you tackle that part first.
So it's a great point, and clearly you have you understand the frustration and the challenges with treating these patients. In my experience and my opinion, really we've missed the window. So the goal is to minimize how many patients are in that category of longstanding ocular graft versus host disease. Because at that point, the lacrimal gland's fibrotic and scarred, and the ocular surface is scarred, and we can treat the inflammation okay, but we can't treat the scar tissue. We can't make that disappear. So that's really um, a challenging situation. What can we do? Again, you can, if there's any evidence of inflammation or new inflammation, you want to treat that aggressively. So you don't want to start with artificial tears and then slowly work your way up. You want to start with steroids, and serum tears actually have a really nice outcome. What's best though for these patients that really are hard to treat with a lot of fibrosis would be scleral lenses. They do remarkably well because it creates a new surface essentially, and it lubricates the surface while creating a new barrier. So these patients do really well with scleral lenses. It's a little bit of a hard sell at the beginning, but ultimately they tend to end up going on that. And the other thing that I like are serum tears. Partly because they're on systemic immunosuppression. So I think they're getting some of that immunosuppression in their tears.
And the second part of that question is, for systemic treatment, is that something usually done by oncology or ophthalmology?
So I would say that if you're going to change systemic therapy on these patients that tend to have a complicated medical history, you want to make sure that you're doing it in collaboration with oncology no matter what. So that's getting back to your previous comment about your relationship with oncology. So the more communication and the more that you work with them, the better that relationship's going to be. So do I tend to change therapy on my own? I don't. I work with them because that's the way that our relationship works. But as soon as I ask for increased systemic immunosuppression, whether it's with steroids or tacrolimus or ruxolitinib or something else, they really they respond and tend to change the therapy. So it goes, that relationship is really important. But you have to understand how complicated these patients' treatments are.
Yeah. Next question. Another thank you for your wonderful lecture. Conjunctival fibrosis is often a problem. How do you go about treating that?
So I think conjunctival fibrosis is both a problem and a diagnostic tool. So I do want to make sure that everybody's looking for it and thinking about it when they're treating these patients. So the challenge with conjunctival fibrosis, one is if it looks active or new, then you want to treat it because that means that there's this inflammation. So you want to treat the inflammation first and sort of get it quiet and turn into scar tissue. Once that happens, though, then you get a mechanical trauma to the eye, essentially every time that the patient blinks or moves their eye. So you sort of have this cycle that needs to be broken. One option is the scleral lenses, which at least can, for some of the day, protect the cornea. I think that that's really our best option. You can also try amniotic membrane, but I don't think that's going to work really well.
Great. Thank you. Thank you so much for answering those questions. A lot of great questions. It sounds like we have definitely some people on this webinar who are actively treating these patients. So that's wonderful, very relevant. It looks like that's all the questions we have so far. I don't have any more. So I would like to thank everyone for logging in tonight. And special thanks, of course, to Dr. Sunshine for speaking and sharing her expertise on the topic. I'd like to remind everyone who's here that when you log out of the webinar, there's going to be a super quick survey that pops up. We really love feedback or suggestions for topics, anything. It's super quick. It's like 2 questions, and then you can type something if you want. Keep an eye out for the next webinar. I think I have one coming in September on AI, which should be very interesting. Hot topic sort of everywhere right now. And then, do you have any closing words, Dr. Sunshine?
I just want to thank you for the opportunity and thank everybody for joining us tonight. It's really wonderful to see so much interest.
Thank you. I would echo that. Thanks everyone for joining. Thank you, Dr. Sunshine. And if that's all, everybody have a wonderful night and we'll see you on the next one. Good night.